I think it's already come.
Can you see?
Yeah, we can see now.
Yeah, it's come. The thing has come. It's come. I think you can start.
Can you hear me?
Yeah.
Yes.
Okay, I can turn the phone off.
Yes, yes. But I think don't change anything here.
You can see the slides.
Yeah, yeah, we can see the slides.
Okay.
Yeah.
Okay. More discussion.
Let's start.
Good morning again. Sorry for technical issues. Is that okay?
Yeah, yeah, fine, fine, excellent, excellent.
Okay. So there are major components in the surfactant that dictate see anti-inflammatory effects. Surfactant protein B prolongs the half-life of the surfactant. Plasmalogen and antioxidant phospholipid. Finally, all surfactants have anti-infective property. Here is the data on anti-inflammatory properties. This is adding increasing amounts of lipids and looking at which is a very potent inflammatory cytokine. You can see with increasing for DPPC, we have decrease in alpha release. The fact SPB prolongs the half-life by secretory phospholipase 8. And see here, this is if we add more SPB, you can decrease the breakdown of surfactant. Third, this is plasmalogen. It with BPD is a non. You can see we have a lot of endogenous plasmalogen. We have and you can see that I showed you zero contains the highest amount of SPB. Again, studies published many years ago, almost 40 years ago, about fighting with gram-negative bacteria. Then surfactant inhibits the growth of gram-negative bacteria. About surfactant only inhibit gram-positive bacteria, but not gram-negative. There are differences in antibacterial properties between two surfactants. Let's look at, are there any clinical differences? Random trials have shown no difference in dosing, lung compliance, length of stay, ventilator, or death or BPD between moving factors, namely surfactant versus cofactor or surfactant versus in continuous control trials. So these are the three large comparative studies. 2005, you can see in the prophylaxis trial, second dose or difference third dose. That's the primary outcome. Compliance, no difference. Finally, in 2005, large study unfortunately was stopped early because very the patients, in spite of nearly 2,000 babies, no difference in 36 weeks post-menstrual age. However, early trial closure prevents from either accepting or rejecting the null hypothesis. Here is the data from those studies. You can see the need for 2 or more doses was not different between these two surfactants. Somewhere around 50 to 60% of the babies ended up getting a second or third dose or fourth. So there is an excellent Cochrane review about If you want to know about all surfactants, this is a review. Here they compared bovine lavage surfactant like alveofact or BESS versus mince surfactant. These studies, and they showed no difference in outcomes between lavage preparation or a minced bovine preparation. It's only one study where they compared 100 milligrams per kilo of all three surfactants, alveofact versus Curacao Surfactant. In this study from Greece, they showed even with 100 milligrams per kilo, the length of stay was shorter in the Curacao compared to alveofact or Surfactant, 62 or 81 days, 48 days. They also, based on oxygen, was lower, 9.9. 16 days. This mechanical ventilation was also lower, significantly lower when you compare Curacao versus Surfactant. Or there are clinical differences between porcine surfactant and bovine surfactant. Okay. All randomized clinical trials have shown significant differences in dosing, onset of action, duration of action, upstate versus based on ventilator and oxygen, death or BPD in babies randomized to Curacao or alpha compared to inactant or Surfactant. I'm only showing you randomized controlled trials. Here are the 6 studies that were published in 1995 through 2011, and I'm showing one of them. You can see the primary outcome is here, highlighted in blue. Lower FiO2, lower peak inspiratory pressure and mean airway pressure in babies randomized to poractant alpha at 12 to 24 hours. Out is less in oxygen pressure variation, total day. And our own study, one of the largest studies comparing, we showed lower FiO2 requirement, less dosing, and decreased mortality, especially in babies less than 30. Now, like from Chicago, lower FiO2 to 40 hours, less dosing, and low volume of dose with Curacao compared to few Boston, faster weaning of oxygen, less early, less babies were intubated and on mechanical ventilation at 70 hours of age. Finally, Distar from Turkey showed faster weaning, fewer doses, rapid extubation, and higher survival free of BP in poractant alpha treated group compared to Surfactant or Miractant. Very quickly, this is the FiO2, the pilot study published many years ago, 1995 by Germany. You can see faster weaning of FiO2 in babies randomized to Curacao, 200 milligrams per kilo dose, faster weaning of peak inspiratory pressure and mean airway pressure. Again, the first 20 days. After that, there was no. In our own trial, we showed that the number of babies requiring 2 or more doses is significantly lower in babies randomized to 200 milligrams per kilo. That is 27% compared to 49 or 41 Curacao. Again, if you use a higher dose, the need for 2 or more doses, additional doses, significantly lower. And I want you to remember. And we looked at all the typical outcomes. We looked at in any trials, pneumothorax, bacteriosis, pulmonary hemorrhage, necrotizing enterocolitis, IPA, rescue need for high-frequency ventilation. There was no difference. We did find a significantly decreased mortality maybe 32 weeks in randomized to 200 milligrams per kilo compared to 100 milligrams per kilo of or Surfactant. Another study from Fuji, higher dose Curacao versus Miractant, 50 babies, showed air leaks was 0. Diagnosed by echocardiogram also lower 32% versus 70%. Ligation was significantly lower, 16% versus 8. BPD went to less BPD and less ROP. Okay, mortality was lower, nearly half, 19. Because small sample size, it was not statistically. Another study from Ankara, extubation in 3 days was 81% randomized to Borac alpha, 56% survived group. Again, p-values shown here. For a baby is required 2 or more doses, significantly lower. BPD free survival is also higher with Borac alpha. Quality sample. Incidence of bradycardia and reflux of volume and lower viscosity. With Borac and alpha, 15%. Bradycardia, 8.8. Why is higher dose beneficial? It's not a new information from doctor to try. We showed that using the same surfactant, the factor from Japan, 60 versus 140 milligrams to a better outcome, lower BPD, less IPH. Right? You can maybe the higher doses had improved A ratio and spear single versus multiple doses, less pneumothorax, higher dose, less mortality. Henry Holiday, 300 versus 600 milligrams of alpha, maybe that got a lower number of patients requiring oxygen than 40%. And finally, from Germany, Albuafact, 50 milligrams versus 100 milligrams. Surfactant, you get better outcome, improved oxygen, less air. So based on this, European guidelines recommend using a higher dose of surfactant if we can deliver safe. So why 200 milligram per kilo? Here is a study from Italy where they compared 100 milligram versus 200 milligram. You can see half-life is much longer, 200 milligram per kilo dose. First dose, 2 hours. Index was also 4. Number of babies required 2 or more doses was also lower, 29% versus 17%. So using a higher dose results in longer half-life, lower oxygenation index, and less need for redose. Again, if you use the 200 milligram per kilo, you have highest phospholipids, you can lower the surface tension. We already talked about anti-inflammatory effects. Molecular species that is very similar to human surfactant, therefore it interacts better with SPB and high amount of SPB, rapid absorption of phospholipids, and I also showed you SPB, you decrease metabolism of surfactant by inhibiting the enzyme secrete phospholipase A2, leading to longer half-life. High amount of plasma has very good antioxidant activity. Remember, preterm babies have less antioxidant enzymes that are developmentally regulated. High amount of polyunsaturated fatty acid helps to rapidly distribute and also again, this is a Cochrane review. They learn differences, clinical outcome between Surfactant and Curasur, including a significant increase in the risk of mortality during discharge, death or PDA requiring treatment, number of babies with one dose that were randomized to Surfactant. They concluded better outcomes. Again, all of these better outcomes, higher dose of Curasur. Here is again number needed to harm, like number needed to benefit. You can also put number needed to harm. death before hospital discharge, 9 strokes, about 900 babies, 20 babies. For every 20 babies, you have one less to treat the baby with Eurosur compared to that. If you use a higher dose, that's better, 16 babies. Death or BPD at 36 weeks, only 3 studies. Again, if you use higher dose, you have better benefits. Number of babies requiring PD treatment, only 3 studies, 4 babies. Clearly, the higher dose, the better outcomes in death or BPD, mortality, or PDA. There's a more recent paper last year from research. They looked at 14 trials, nearly 1,500 patients. Looking at 200 milligram per kilo Curosur, all bovine surfactants. Similarly, here, outcome is BPD. Here, BPD or mortality, and here, BPD or mortality. The higher you can see any dose, there are better outcomes with Curosur. And I'll show you better. Here is higher dose with all other bovine surfactants. You can see relative odds ratio significantly lower. Confidence interval is less than 1. So clearly, you have better outcomes if you use a higher dose. How can we improve? Most of us CPAP, right? But the CPAP failure rates are high. There are some modifiable factors. There are 4 things I want to remember. Antenatal steroid use, postnatally, an optimal surfactant, and post-surfactant if you manage babies with IPP rather than nasal CPAP, and finally, early rescue surfactant treatment using the FiO2 criteria of 0.2 or higher in babies on CPAP. Here are the data. This is a paper published from Netherlands last year. Look at this is less invasive surfactant administration. 185 babies. They showed is a lower surfactant dose, no antenatal steroids, which are clearly modifiable by clinicians. And the obstetrician is postnatally we use a higher dose and decrease missed failures. The missed success in green bar, missed failures is in the red bar. See failure defined as early mechanical ventilation for 7 hours of life. The lower dose factor, success is only 63%. 8 years is 86. No antenatal steroids, babies on CPAP, much higher, 20%, 7.8. CRP, evidence of chorioamnionitis or inflammation in the baby, if it is more than 10 milligrams, is also significant, high failure. Oxygen for FiO2, again, higher FiO2 you have before you give surfactant, failures are higher, and babies that fail have more IVH and increased survival, mechanical ventilation. You can see survival without serious is much better if you can manage the baby. The higher dose of surfactant, not antenatal steroids, you have 76% without complications compared to 57%. Again, in this review, they showed PISA or missed minimally invasive surfactant treatment failure. 200 milligram per kilo dose was 14% compared. He published a paper in 2012. After INSURE, we managed randomized. Again, this is modified. Change your practice. They use post surfactant MITV. Extubation post 36 also significantly lower after surfactant and post surfactant treatment. The need for additional doses is lower, not statistically significant. Again, there are many studies from 1990 compared comparing CPAP versus NIPP. And these three trials, Google from Israel, Hungary from Philadelphia, and our own trial, as you can see, combining higher doses of surfactant and NIPPV, we have less PCD. This is not a primary outcome. What about timing? So I told you about the type of surfactant, the dose that you'll have a better outcome, or the modifiable factors. Timing. 1999, Berger published a paper looking at early versus late surfactant. Early surfactant are on CPAP, and the FiO2 was 0.37, 0.35. Longer, you can see surfactant early mechanical ventilation death for 7 days or 50 are significantly lower. 51% with 27% versus 70%. So if you wait for too long on a baby on CPAP, you're going to fail more often. You end up in either before discharge or in the first 7 days. 10 years later, in 2009, Rojas published in South America very similar findings. Early treatment, babies are on CPAP within 1 hour. Late means FiO2 than 0.5 or longer than 2 minutes. You can see need for mechanical ventilation was only 26% and 39%. Pneumothorax was 4.5 times like 2% versus 9%. Two large randomized controlled trials have shown and babies on nasal technique. So we have gone from endotracheal intubation, giving surfactant, to technique and rapid extubation, to using a catheter, angio catheter or feeding. But these are mesh technique, mask airway, or installation. We're going from invasive approach to non-invasive approach in terms of technique of surfactant preparation. What's the rate? Sure was introduced by Professor Berger, and this is basically a technique that involves administration in endotracheal tube or a feeding, but provide partial pressure ventilation after surfactant therapy, and you can extubate the baby within 2 to 5 minutes. Problem: many of the centers after ensure they do not extubate the babies after giving. What about LISA? LISA technique typically involves surfactant administration in a small tube when the baby is spontaneously on CPAP or an NICU support, usually without any medication or sedation. A number of names, there are 11 different missed from Australia, LISA from Austria, avoidance of mechanical ventilation, Germany, without intubation from Germany, non-intubation surfactant in another Germany, on shoot, known as a guest surfactant intubation from Spain. So as you can see, all of these techniques or names involve just less surfactant intubation, something other than endotracheal. Here are the methods. We wrote about techniques and what made. So this is the own method from Germany, Australia. They used feeding or a 16 vascular catheter, angio catheter. Sometimes they use some bigger forceps, different size tubes, doses of 100 to 200 milligrams per kilo, time from 30 seconds to 1 minutes, pre-medication. Majority of the centers used atropine. Some of them used fentanyl or sedation and reversed with Narcan. Support method in Australia, and some studies none was used, like ECALME study. It is a video. I hope it will play. The babies are on the nasal CPAP. This is my friend in Vienna, Austria. He gave me this. video. You can see that actually in the caffeine increase the respiratory effect through giving surfactant. They're one of the few groups where caffeine is in the delivery room as part of the resuscitation.
Die Magen jetzt nicht. Das Surfactant haben wir noch gar nicht reingegeben.
If the baby is breathing spontaneously,
Ich muss jetzt sehen, ob jetzt noch was kommt.
allowing the baby to aspirate, basically the surfactant that's being pushed in.
Schon mal
This is exactly what the use it. So what are the data? So there are 6 studies, 895 babies, comparing Lisa versus followed by nasal CPAP. This is a meta-analysis published. They showed that less positive pressure reduction in BPD alone. Lisa technique to clearly, I think slowly European countries are moving towards Lisa rather than it should be. In the US, only about 10 to 20%. It is looking at the outcomes. Death RB 36 weeks. 36 risk significantly lower. Need for mechanical ventilation less than 2 hours or at any time was also lower. Only adverse effect was reflux medication. More common. You have to slow down when you are administering surfactant. If the baby is coughing, lagging, or bradycardia, that is either reflux, vague bradycardia. To fight that, we're using a large one surfactant. We need to give only over 1, 2, or 3 days. No adverse effects like pulmonary or pneumothorax. Here is list. This is more recent published in last year from Turkey. 5-year experience, 183 babies. They compared Lisa versus insured ICU, 25 to 29 and first dose of surfactant about 2 hours. The dose of life was significantly reduced, 57% versus 42%. Non-invasive was lower. BPD, moderate severe, 12% versus 22%. Comparing these two techniques. Again, criteria for surfactant treatment in their FiO2 greater than the first 2 hours of life. 500 feeding tube, they gave surfactant over 30 to 60 seconds. Each tube was given to endocrine. They did not use any medication. What about in late preterm babies? This is moderate to babies, 32 to 36, a randomized controlled trial from Canada, and they showed that need for mechanical ventilation or pneumothorax needing a chest tube was significantly lower, 33% versus 90% in the standard group, and pneumothorax alone not different. Number of babies requiring more than 2 doses not different. So they used Surfactant in this trial, 4 ml per kilo by a 5 French feeding. Basically had a level under direct pressure. With the baby's mouth open, moderately, they gave pre-medication atropine and fentanyl. Reflux of the medication was 66, very high, likely due to large volume and keeping in the mouth. If you keep the mouth open during surfactant administration, you're losing the positive pressure or seizure. That is a good idea to keep the mouth closed. So these are the guidelines we use in our center. Of pre-medication, atropine, 20 micrograms per dose at minutes before the procedure, fentanyl 2 mg per kilo, IV 3 minutes before, and give it over 3 minutes. Keep oxygen at the bedside to remove the fentanyl, like chest wall rigidity or spasm. Occasionally, we may have to have if the naloxone is not effective. Line 0, there are concerned about fentanyl use. I prefer option 2, 20 micrograms per kilo per dose to increase the bradycardia, or sucrose, single dose 0.12 babies less than 32 weeks or 0.4 bigger babies. Oral sucrose affects 5 to 8 minutes. Finish within 5 to 8 minutes. So you apply at the tip of the tongue. Optimist, which is collaborative pair trial investigating the multinational randomized controlled trial run by Peter Barger of Tasmania. This is the catheter we use in the Optimist trial. We are part of this trial. 25 to 28 weeks gestational age, less than 6 hours of age. The FiO2 is equal to or greater than 0.3. In this trial, we use Skiros of 200 milligrams per kilo dose. Criteria for intubation, FiO2 more than 0.45, post-surfactant, 606 baby sample size, 475 babies have been enrolled as of this month. The study hopefully will be completed in a year or so. This is the LISA, or missed angio catheter. This regular BD catheter available, 16 gauge, 5.25 inches, adult ICU, cardiac ICU, they all have this catheter. You could go and get it from them and start using the LISA or angio catheter. Much easier to intubate babies because it's relatively stiff. You can use your fingers without a need for McGill forceps. I already showed you this slide. So, okay, what are people doing? This is a large study looking at nearly 13,000 babies from German neonatal network. Many centers in Germany that participate, almost all the centers. You can see from 2009 to 2017, a significant increase in LISA technique, and tube surfactant or intubation and giving surfactant is much lower now, and babies requiring surfactant is actually higher because with the LISA technique, more babies are getting rescued with early surfactant therapy. They also reported outcomes. You can see BPD at 36 weeks. The gray bar is LISA, dark bar is you can all just that were given surfactant via LISA technique compared to Insure technique. They also reported IBH, also significantly lower at all station age with the LISA technique compared to Insure technique. What about laryngeal mask airway? Unfortunately, we do not have a laryngeal mask airway that you can use safely in babies less than 1 kilo or 800 grams. So this randomized control trial from a multi-center trial from US, published in 2018, where they used mean birth weight about 2 kilo, gestation age 32 weeks. They gave atropine and sucrose, 1 ml to the tip of the tongue, surfactant treatment by LMA, decreased the need for intubation. Odds ratio 0.3. Number needed to treat is 4. However, if you look at the control group, again, 64% of the babies received surfactant later on. With LMA surfactant administration, it is. So they also aspirated after LMA treatment. They found 18% of the babies had more than 50 mL surfactant dose aspirated from the stomach. So even with LMA technique, you are not going to deliver all the surfactant into the trachea. Some of them can be in the stomach. Again, they found better response in babies where surfactant was given, the FiO2 was less than 0.35. So they had babies, the FiO2 up to 0.4. So clearly, early surfactant is better than late surfactant. What about nebulization? It's a recent study from 2018 looking at in babies between 29 to 33 weeks, and they showed in babies on nasal CPAP and the FiO2 was less than 0.3 using this special vibrating mesh nebulizer and PiroSurf. They showed babies requiring intubation significantly lower in the group of babies, bigger babies, 32 to 33 weeks. In smaller babies, it did not make a difference, not statistically significant. Here is this technique is being currently worked out. Finally, at what FiO2 should we use surfactant? What is 0.3 or 0.4? So this is a retrospective multi-center trial from Tasmania and Australia, Peter Dargill published. And looking at the receiver operating curve, here is the area under the curve. So value of 0.5 means no predictive power. 1 means perfect prediction. They found an area under the curve of 0.8 or 0.81, and the FiO2 was 0.3 or greater. In the first hours of life was a key predictor of CPAP failure and is associated with adverse outcomes in preterm babies, both between 25 to 28 weeks or 29 to 32 weeks. So up with a combined area under the curve of at least 0.8. They looked at highest FiO2 value in the first hours in tiny babies, highest FiO2 value in the first 6 hours for mature babies, 29 to 32 weeks. They also looked into all the other factors, gestational age, birth weight, antenatal steroids, cesarean delivery. A second study that was published last year from Poland, looking at what FiO2 should be used. Again, a predictor of CPAP failure, a multi-center prospective study, 389 babies were enrolled, and they came with similar number. An FiO2 of 0.29 in the second hour of life was identified as a key predictor of CPAP failure with a sensitivity of 73, specificity to 57%. You can see area under the curve, 0.7. And babies that failed CPAP had higher mortality and morbidity in terms of IVH, BPD, and need for mechanical ventilation. Finally, a third trial from US in Texas, Kakili et al. Published the paper in Journal of Perinatology in less than 30 weeks, a single center study. You can see they use radiographic criteria for severe RDS and maximum FiO2, 0.3, but 2 major predictive factors. They had a modeling cohort, and then they validated these 2 variables, and they found FiO2 have 0.3, second hour of life, and radiographic severity of RDS predicted CPAP failure requiring mechanical ventilation. So here are the updated European consensus guidelines, which are updated every 3 years. This is the most recent update last year. You can see babies with RDS should be given a natural surfactant because we don't have a good synthetic surfactant as of today. Early rescue surfactant, if there is evidence of RDS in very low birth, in extremely low birth weights, whose mothers have not received antenatal steroid or baby was intubated as part of resuscitation, no FiO2 criteria. Suggested protocol when the FiO2 is more than 0.3 on nasal CPAP. Again, the recommendation of CPAP went from 5 to +6. Poractant alpha 200 milligram per kilo is better than 100 milligram per kilo of poractant alpha or piractant, evidence A. Lisa is preferred method of surfactant administration for spontaneously breathing babies. Sometimes the babies may require a second or third dose. So there are problems with Lisa technique. Okay? And here are suggested corrective action plans. Most babies, when you try to intubate, they get bradycardia or desaturations. You could use atropine with fentanyl or propofol in some European countries they use. Studies have shown that you can reduce apnea by giving caffeine before LISA technique, like they use in Vienna. LISA failure on first attempt can be minimized using sedation, dislodgement of the catheter. Some have recommended direct visualization during administration, but I do not believe it's a good idea because you will have reflux of the medication and you may not be able to deliver all the surfactant. Cough or gagging, give it slowly. Reflex, again, you can use a small catheter, small caliber catheter, like LISA catheter or an angio catheter, rather than a feeding tube. Reflux can be reduced with smaller volume, lower viscosity, like Curosur, reverse tendon influx. So while using surfactant treatment with LISA technique, keep the head end of the bed at 12 to 15 degrees elevated. That way reflux can be minimized. Repeat LISA procedure. If you use a higher dose, you don't have to repeat it that often. And finally, you can improve the LISA success if you manage babies post-LISA with NIPPV. So I think LISA is here to stay. It's no longer just a fashion. So I think it has been shown in randomized controlled trials to be beneficial if you use the LISA technique compared to the INSURE technique that we've been using. I hope you're all using LISA technique, or at least should evaluate them. So in summary, based on evidence I've shown you, type of surfactant, Curosur for poractant alpha, 200 milligram per kilo for the first dose is better. Timing, when they go to requirement 0.3 or greater. Technique, LISA technique using a small volume catheter and a small caliber catheter, like a LISA catheter or an angio catheter. Dose, clearly 200 milligram is better for the first dose than 100 milligram per kilo. Thank you very much for your attention. We'll be happy to answer any questions at any time.
Can you hear me, sir?
Yes.
I was wondering why that aerosolized surfactant delivery failed. What was the reason why it failed? Hello?
Problem is, we have tried aerosolized surfactant for, hello?
Yes, I'm listening. Yeah, we can hear
Hello?
you.
Yeah, I can hear you.
Yeah.
Okay. The problem with the aerosolized surfactant is whatever aerosol nebulizer you're using, whether it's vibrating neb, as soon as aerosolized, the particles get into the trachea, it becomes bigger because it absorbs water. The mass median aerodynamic diameter of the surfactant molecule becomes larger, and therefore they end up sitting in the trachea or in the bronchus. It doesn't get delivered to the alveoli. That's the biggest problem with nebulization or aerosolization of surfactant, is as soon as it gets into the trachea, the molecules absorb water, becomes larger. So you want to have a surfactant that actually can be delivered as a small diameter molecule, and that is very difficult in a baby whose trachea and airways are moist and wet. So that's why some people are trying atomization. In preclinical studies, using a special technique called atomization, you can maybe improve the delivery of the surfactant. In a piglet model, they showed that a group from Italy, Federico et al., and they believe that this new atomization technique may be a true non-invasive form of surfactant, but we do not have any data in babies yet. I hope that answers your question.
Any high frequency use after surfactant will use better, what do you call it?
Really randomized control trial. Okay. Can you hear me?
Yeah, now I can hear you.
Okay. Yeah. So basically, the whole idea of giving early rescue surfactant therapy is to avoid ventilation, like invasive ventilation. But if the baby has severe RDS, congenital pneumonia, and the baby is on high frequency ventilation, there's no data on comparing surfactant administration during high frequency ventilation versus conventional mechanical ventilation in terms of distribution. better to deliver nitric oxide gas, right? Same way, I'm speculating that during high frequency ventilation, if you give surfactant, you may be able to deliver. The problem is you need to put a catheter through the endotracheal tube. If you give it proximally at the ET tube, most of the surfactant may reflux back, because during high frequency ventilation with active exhalation, you may not deliver all the surfactant. So I would still recommend using conventional way of giving, either ensure if the baby is this. Unfortunately, you need to disconnect the baby from high frequency ventilator, keep the baby on CPAP, or turn off the oscillation and then give surfactant through a medication administration catheter or MAC.
I leave for any other questions. What's your protocol for SNIP PV and oxygen targets?
I lost the audio. Could you repeat your question?
Yeah, I will repeat it. See, what is your, because there's a lot of controversy on the oxygen saturation targets the first day, the third day, the first week, and during early BPD. Because after reading that chapter, I want to be precise to the audience that what do we recommend the first day.
Or you can type it in.
Yes.
Couldn't hear you again. Please make it short or type.
Yeah, the oxygen saturation targets in a preterm below, say, 28 weeks. So first day, third day, 1 week, and early BPD.
Yeah. So our guidelines, which we have published, again, as our own experience for more than 10 years, we use 85 to 89 in babies less than 28 weeks from first day one until they get to 32 weeks post-menstrual age. Then we'll go to 90 to 94. There are 5 studies have been published after the support trial and boost trial. There are concerns about increased mortality. But remember, in those studies, babies were maintained on 85 to 89 from day one until discharge, or as long as the babies are on supplemental oxygen. It's a bad idea. As the babies are growing rapidly, the oxygen requirement goes up. Therefore, you need to liberalize saturation later on. Early, low, late, high is probably the best approach. People are now slowly coming back because 5 studies have been published after the NeoProm study was published, where centers switched to 90 to 95 from using low to high, and all 5 studies, one from Sweden, one from Germany, one from Australia, 2 from the United States, all of them showed severe ROP and more BPD and no change in mortality after going from low to high saturation. So I think probably this is a controversial issue, but I think at least if you don't want to go too low, somewhere between 87 to 91 or 87 to 92 at the most is a compromise.
Good evening, Dr. I'm Dr. Arif. I just have got 2 questions. Can you hear me?
Sure. Yeah, yes.
Okay, so normally recently, since the time CuraSurf has been used, my question is, should we take consent from people before giving surfactant? Because we have come across patients who are like Muslims and they're quite concerned about CuraSurf. At the same time, like recently we had a patient, he's a Hindu, but he did ask the question, you're giving surfactant?
Yeah.
What's the source of surfactant? So when we told them it's from the minced cow, so she said, okay, no, I don't think I want to do that.
Yeah.
How do we handle? What's the policy there? That's my first question.
Yeah. So the question about religious objections versus coming from either a cow or a pig, it depends. Again, this is not, you're not ingesting. So our patients, even on randomized controlled trials, none of them said no based on their religious beliefs. And they have actually, the company that makes CuraSurf, KC, has a certificate saying from Rabbi as well as from Prophet that they can be used in Muslim population or Hindu population or Jewish population. So because we are not ingesting it, this is just like when we had pork insulin, we had no other option. Now you say, well, we have an option. If somebody doesn't like a porcine surfactant, can I give bovine surfactant? But the data is so strongly in favor of porcine surfactant, and they don't object.
Thank you very much. I got a question. It's a clinical question.
Yeah.
So currently, I have a baby in the unit who's born to an elderly primate.
Yeah.
Baby was born at 27 weeks of life, and mother had hypertension, diabetes, chorioamnionitis. The baby delivered. Of course, she was intubated. We gave 2 doses of surfactant. We could wean the parameters successfully within first 3 to 4 days. She was doing very well. We put her on PSV mode of ventilation, and our plan was to definitely extubate and just provide him some non-invasive care. But what happened was, while she was on PSV, suddenly PCO2 started to go up. The lungs became again completely wiped out. And only yesterday we had to put him on high frequency ventilation. The lungs are wiped out, CO2 is high. My question is, can I give surfactant now? She is now 9 days old.
Yeah, absolutely. There is no upper limit for surfactant administration. There are no randomized one randomized control trial in babies with bronchiolitis and RSV, but there are many studies, observation studies have been published where they're called post-surfactant slump. Babies got surfactant, they were on room air, and then after 5 or 6 days, they look like they have RDS on day. We call
So we did an echo, of course.
Of BPD.
So we did echo to rule out its PDS contributing to this problem.
So surfactant is enough to go up, extubate them. Yes.
So
PDA.
So I can administer one again surfactant to the baby. She's 9 days old. White out.
Yeah, absolutely. You can give surfactant, and then if the PDA is causing problem, you may want to treat the PDA if it is hemodynamically significant.
My one more question: if baby is intubated, more question. If baby is intubated, and if I have option of using double lumen endotracheal tube, is it preferred over or the standard endotracheal tubes to administer surfactant?
I think it's going to be, we have to this baby is unstable, it's on high frequency. When you extubate,
no, I'm talking of a general question. If I have option of
go ahead.
So which ET tube is preferred, double lumen or the standard ET tube?
No, standard ET tube is because if you use a double lumen ET tube, the effective internal diameter becomes less, and therefore you increase the resistance. That's the reason most people would recommend single lumen. That's why even on high frequency jet ventilator, now they changed from a double lumen special high load jet tube to conventional ET tube.
Thank you very much. Thank you.
Thanks for your question.
Good morning, Dr. Ram. How are you?
Good morning.
Actually,
I'm good. Thank you.
Yeah, there was little problem of the audio, but it was a wonderful presentation.
Sorry.
I have a practical question regarding the LISA and the MIST. What I feel practically, the LISA, you need to use a Magalhaes forceps, and sometimes smaller babies with a very small oral cavity, likely to cause injury or failure. And you already showed a slide that LISA and MIST failure are resulting in higher incidence of IVH and mortality and things like that. We're a bit concerned about it. That means every time you do LISA, it should be taken into consideration that it should be successful. And MIST is probably better that you are going to use the angiocath and it would go directly into the trachea. So, and you
Yeah.
may not be using a megaly forceps.
Yeah. Good question. Again, depends on the experience. The Germany and Angela Krebs from Cologne or Catherine Klebermas from Vienna, they all are used to using a feeding tube and Megel forceps. In my system, we are not. So I strongly recommend and our center, we only use angiocatheter, which means